this is
Emergency
emergency
nurses trends
trends
and
and practice.
yes,
Take two. Okay.
gotcha.
We got it that time for a little bit. So this episode, we're going to talk about triage
I love it.
and some topics. I think, what is triage? Because there could be people that are watching that don't know what that is in the emergency
Yeah.
world. So what is triage, and then some of the emerging trends that we're seeing with increased census.
Yeah.
Do you want to start with triage? Is like your babe.
Yeah, it never used to be. I love it. Triage is my favorite. It's basically sorting.
It is.
It's assessing and sorting in a way. Picking out, are you sick, sicker, or the sickest person that's walked through the door? And what location in my institution can I send you at? And now it's what resources do I think you'll need?
And then what tool are we using as ER nurses in the front of the house to help establish this picking and prioritizing?
So there's actually several tools out there. We are using where we work the ENA backed ESI, which is Emergency Service Index, right? Kind of like assesses how many resources you need. But the another tool out there is there's a Canadian tool. I forgot the third one, but third one is like an ESI, like an urgent, emergent, urgent, can wait
Okay.
tool. So there's like three big ones out there, with the ESI being the biggest one. Biggest one nationally is becoming more international.
And we use the ESI, which you said.
Yep.
And how many levels are there within the ESI tool that we use?
All right. So the ESI tool is a rating system, 1 through 5, 1 being the most resources the patient's going to require, 5 being, it sounds weird because it's backwards, because 1 is the most resources and 5 is the least. I want those numbers backwards. Every time I do it, I'm like, oh.
So 1 is the sickest.
The sickest, yes. When you think about sick, it's sickest right now.
Yes.
Because you can be chronically sick, and that does factor into it, but sickest right now in the moment.
And then 5 to least sick in that moment and could potentially wait in the waiting room safely.
Could have probably gone to a doctor's if you were tied into a doctor's system.
Okay, so that's kind of what we use at our institution. And then, so obviously it's winter and we're seeing increase flu, RSV, pneumonia, COVID.
A lot of pneumonia,
especially in the pediatric population.
Yeah.
What is it called? It's the specific.
Oh, mycoplasma.
Thank you.
Mycoplasma pneumonia is what's very popular.
Yes, and definitely in that PD population, 2 out of my 3 kids had it.
Yeah, right. And then we know someone else who was
recently.
Yeah.
Okay, so increased census that's happening now. We had a little lull over the holiday period, but now we're kind of picking back up. So what are some things that we're reading, seeing out there in the emergency world that they're doing to help deal with the increased census in triage?
Ooh, hospitals are getting creative. They're using every available space they can and seeing how and what model they can turn it into. A lot of places are going with what they call a provider at triage. So whether that be an APP or an MD, where places have it set up differently. A lot of institutions seem to have it set up where they come in the door, they get registered, they get triaged by the nurse, and then they'll get sent over. The APP will do a quick MSE, which is a quick medical exam, and then they'll start that and start the orders, and then they move off to area B or whatever. And then some are using it that the providers in triage, that they only see those ESI 4s and 5s and just own them from the waiting room, so you never see the back of the house.
Okay. So we don't have a provider in triage in our institution, but we have standing orders. So I'm not sure what other institutions, I'm sure there are several institutions out there that also do the orders, standing orders in triage to help get workups going.
Regionally, I think a lot of the docs group or the hospital systems around here, the standing orders are very much cultivated to the clientele they see. So and how their system works. Ours are very based on what is out there right now. Where we work, the standing orders are very, very limited compared to what
and they used to be more broad.
Yeah.
but we had to scale it back.
Yeah.
Yeah. So provider and triage, that's one thing that we're seeing. And you had mentioned earlier when we were kind of chatting about this topic, the vertical flow model.
Oh, yeah, that's big. Bigger in, well, they have it locally too, but I know it's bigger out in the Midwest where it's a great idea. What basically is think of it as the patient comes in, we have to see them, right? We can't send them off or do whatever. They get seen, they get ESI'd. Um, that point, so that's where you get your triage assessment. If you have a provider at triage, you would start there. They would do their quick
The medical
assessment,
screening, yeah.
medical screening, exam, and then they would enter your orders and you would go off to area B to get your orders done. You'd go to area B, get, they would institute those, like if it's lab draws, that type of, they would start that. And then once that part was done, you would move off to area C, which is kind of like waiting for those results.
Okay.
Or area C could be waiting for those results slash finishing the treatment. So if it's a bag of IV fluids or if it's Tylenol, you'd go there and then you would go to area D to get your results. And then, but area D, you'll have get your results slash dispo either home or admit.
And now, do you think this would serve the population that has a lower acuity?
Oh, 100%.
Yeah. So this is like your 4-5s.
Yeah. And even some of your 3s, because if your 3, so in terms of a 3, like think of your like abdominal pain patients, right? A lot of them that are coming in through triage, they're walking in.
Mm-hmm.
Usually triage is ambulatory. So the triage as a physical location is ambulatory. So you're walking in, I mean, some end up going maybe to the OR, being admitted, but most of them get a workup and can go home with some sort of plan, whether it be, follow with the gastroenterologist, or, keep a plain diet, or fluids and some antiemetics.
Sure.
So you could do some 3s.
Some 3s, yeah. But primarily those
4s and 5s.
Yeah.
Some really, really high volume places, the 4s and 5s don't ever leave triage. They don't make it to even vertical flow. Because in APP, that's where the providers are, right? So your APP will see you and just get you out of the way.
I would love to see that model in action.
Yeah.
I would love to see that in real time, in person, and watch that flow for like a couple of days to see how that works, because it seems so much more effective for an LIP or an MD, whoever, and the RN to simultaneously see that patient at that initial time of triage and start the treatment plan from there.
Yeah, and it actually, so for places that have like high wait times, it actually, you decrease revenue loss, because by having someone do a medical screening, you can bill differently.
Right, I'm sure.
And then you have someone in that provider who's assigned to like the triage waiting area is also interpreting results. So now those patients who are waiting are not leaving. They could be leaving, but they're not leaving without at least until results interpreted.
Sure. Which is a huge risk for the patients that we have out there that we're completing standing orders on, and we're not able to have that.
Yeah. And I don't know if it's just a Massachusetts thing or if it's a national thing, but the big transparency with labs and stuff. So with electronic charting, right?
Yep.
So it even happens now in the outpatient world. Your doctor says, okay, I'm going to go send you for lab work. You get those results before they call you and tell you what to do. So now that happens.
And you're on Google. Like, what does this mean?
Yeah, and that happens with the hospitals too, right?
Right.
So, I'm drawing your lab result, or I'm sending you for an x-ray, and you're getting your result before you're getting seen by anybody.
Right, and they're reading those results as either normal or not normal, and they're like, oh, these are normal, I'm out of here.
Yeah.
I came, I was seen, I got what I needed, and now I'm leaving, which we all know isn't really the best for the patient at the end of the day. They really should be seeing a provider. Right. All right, what else are we seeing out there in triage world?
AI.
So I think what
AI is coming to a neighborhood near you.
AI is everywhere.
Oh yeah.
I mean, it's everywhere.
Yeah.
But I think what we're seeing, and we can go off on kind of a big tangent about it, but we'll try to keep it mild. I think AI, is good and bad. And I think that in the nursing world right now, because we have a lot of nurses out in triage that are a lot younger as far as experience goes.
The entire nation, right? The nursing world kind of uprooted, like became extremely chaotic. All of healthcare became extremely chaotic during COVID.
Right.
We were already starting to go that way in the specialties where the baby boomers were getting ready to retire and we weren't growing fast enough. And then COVID happened, and especially in emergency rooms, every emergency room nationally saw like a 40% turnover rate. We're still catching up to that.
And how many years has it been now? Almost 5.
Yeah.
It'll be 5 years in February.
Yeah.
That we had started dealing with COVID and like those rapid changes in healthcare. So because of all that rapid changes we've had, initially during that COVID surge, we had a ton of nurses that were near retire.
Yep.
So we had nurses in our department that had been here for 25, 30 years that were like, you know what? I'm done. Retired
Put my
early.
time in, yeah.
Yep, retired early. And then we had nurses that, couldn't cope kind of dealing with COVID, which is totally fine,
Yeah.
Who left emergency medicine altogether. And that left us with very young nurses.
And then it didn't, whereas the corporate world shut down, healthcare did not.
Right.
But how these people learned did. So now you went from a healthcare nursing model of,
Oh, this is such a great point.
right? We went from a nursing model of doing everything was in person.
Yeah.
Your clinicals, all that, to
even your learning, but your learning was in person.
Learning was all in person. It was very rare. There were a few programs that had some hybrid learning, but those were usually at the graduate level. So entry level RN learning was all in person,
right,
to 100% remote.
Such a great point.
And that's also where AI came in too, right? Like that remote point click,
right,
health assessment, all that. And so those learners came into healthcare. So that's where AI kind of helps them put it all together, those pieces that they didn't really see.
So with our AI software that we are currently using in Triage, I'm sure there are quite a few out there, but
I know of 2 definitely, but I'm sure there's more.
Yeah. I think one of the major benefits, and this is the whole reason essentially why we were talking about these young nurses, is because AI is going to help them get the correct answer of who should be waiting and who should not be waiting.
Yeah, AI helps them in the way that AI helps them, at least the AI software we have, is it looks at things that a new nurse doesn't think to ask. And I'm going to use my own family, throw my own husband under the bus. If he were to go into triage to a new nurse says, "Do you have any medical history?" He's going to say no.
Though he's on what medication?
Yep, that's right. That's
what
right,
medications does he take?
He's on cholesterol meds and blood pressure meds.
But to him,
when you're married to a nurse, you're probably on something.
Yeah.
Those are his.
But to him, I'm sure he's been taking it for years and
Yeah.
it's under control. So why? That's not medical history to him.
And you wouldn't know that because his provider is private practice and they're not tied into our health system. So you wouldn't necessarily see that in his medical record.
Sure.
The beauty of AI is it can pull into a lot of other institutions' medical records and say, "Oh no, this guy
right
has this."
Right. He's on cholesterol meds.
Yeah. He's on an antihypertensive.
Right.
Yeah.
I think that is super helpful for those newer nurses, and the amount of kind of digging that the AI does behind the scenes.
And it does it so fast.
Yes. I think it's interesting that it essentially reads the chart for you and it comes up with a summary of how safe this patient is to wait based on medical history, medications, allergies, previous surgeries, visits, even keywords.
And what you also entered it.
Right.
It looks at all of it. Yeah.
Let's use the A&O example.
I was just going to say it. You got it before me. Go for it.
Let's use the A&O example because it's perfect. So when we first got the AI software, we were so used to typing A&O times 3, right? Alert and oriented times 3. And that was
alert oriented. There you go. There's times 3.
That was kind of the standard for documentation. And we had come to learn that really that wasn't the standard anymore, that the standard was A&O times 4. Because it was awake, alert oriented to self and situation and, a couple other things. And when nurses were initially starting to use the AI software that we got, they were typing A&O times 3. And the software was like, wait a minute, this
something off.
Something is off. This could be a stroke or, something else. Like, think about it that way. And that wasn't the case. It was just that current nursing hadn't caught up with that change to the A&O times 4. So we had to really educate staff that it's no longer A&O times 3, that A&O times 4 is the appropriate
Yeah.
documentation. Um,
I will say the software does a great job reading or interpreting most of the times, not 100%, um, nursing shorthand. Because nursing shorthand is not standard anymore. So I went to nursing school during
there were only certain
the great
abbreviations,
the great written world where you used your abbreviations.
but there were standard abbreviations that
Right.
you could use.
Right. And now everyone kind of makes up their own. I mean, we see it when we're auditing charts and stuff like um, BIBS or whatever brought in by
EMS, that's what they put,
EMS,
yeah.
you know, BIB brought in by is not a standard
Right.
abbreviation, but people use it.
Right. And I bet
Yeah.
if you went into the ED now and said, what does this mean? They could totally tell you. But if you referred to any sort of nursing medical book, that would not be there.
No.
But it is interesting how the software learns and it picks up on those keywords. And we're able, I think some of the things related to education that's really neat about the AI, and I'm going off topic slightly, but is that it can help us see where nurses need additional help,
100%.
which I think is kind of a whole different aspect of what it's doing out in triage, but what it can help the
Well,
nurses
it helps
learn.
us figure out what we need to help to put that picture together.
Right.
Yeah.
Which I think is cool.
Yeah.
It's been hard to get there just simply because of time. But I think that is a huge potential to teaching to what they need without them even realizing it,
Yeah.
because we can pull that data.
The trends are neat too. That's the other thing with the AI does, and with just charting in general, right? So when someone says, I have chest pain, you're able to see now the world has changed with triaging because I'm able to see, I see that you had a visit recently at the other hospital or something like that. So that really helps with triage nursing too. We don't use it with ESI to determine your factor, but it won't be surprising with the way healthcare is changing if that becomes a trend too.
Yeah, I think the AI, I think it's neat. I think there's a lot of potential in it that we've just not tapped into
I
yet.
think it's going to be huge for triaging. It wouldn't surprise me, and I know some hospitals do. So this is the other thing that hospitals do with triage. They do a self check-in.
Like a kiosk?
You got it. And I know one of
So
the
you've got to be well. You have to be well if you're coming in and you're checking yourself into a kiosk.
they do it. You do it sort of at urgent care too. So there's an urgent care locally that you go into, and you put your name, your date of birth, and you put like your chief complaint stuff in. So you then go see a registrar, but
Sure.
it's a quick way for
Just to say, like, hey, I'm here, essentially.
Yeah, it almost puts your name in line. It's almost like call ahead seating from the 99.
I suppose. Oh, do you remember when we had the buzzers?
I know. But a lot of hospitals use that for triage too, because there are facilities out there that use, I guess it's a form of AI in a way, right? It's technology at triage that I can go on to. Our hospital doesn't currently do anything like this system, but there are hospital systems that you can go on and see what the ER wait times are.
Yeah. Yeah.
And then you can fill out the form
and wait in line, essentially.
and virtually wait in line. And then there is somebody watching that virtual line to be like, no, you need to call an ambulance, like to
Right.
let you know. Yeah.
Oh, like if I'm checking in with chest pain.
Yeah.
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 All right. What else we have on our list?
Oh, I don't remember the list. I have to look. And it's sad. I just wrote the list too. All right. We talked about wait times, but
Yeah.
wait times are, what we're doing marketing.
Oh, yes. So hospitals, we have been seeing kind of marketing to the community, re-educating, I should say, to the community, essentially, of
Using all platforms, right?
Yeah.
You're seeing it on billboards.
social media.
Some people actually still buy a newspaper. It's in
Yep.
there, and social media, really.
And the radio.
Yeah.
It's on the radio.
Oh, I haven't heard it recently, but
So they're essentially educating the community with how you're supposed to use an emergency room, how you can use an urgent care, and what like symptoms and complaints would go to an urgent care, what symptoms and complaints would really go to an emergency department. I would be interested in the numbers.
I haven't seen any data on it.
I would be interested in the numbers to say prior to kind of educating the community, was there a decrease in the use of the emergency department and an increase in the urgent cares and kind of where the complaints went?
Right.
because I think that re-educating the community is an important piece because most people don't know which way they should go.
Yeah.
They feel like, well, if I go to urgent care and they tell me, no, you got to go to the emergency room, I just wasted my time.
And I
So
feel
why
like
not just start there?
if people feel sick, they feel like they need to get checked out. And there are physicians at urgent cares. A lot of them do have like the APPs, PAs, um, but they don't. I think they don't because it's not in like a hospital clinic setting. A lot of the, at least around here, a lot of the urgent cares are like in a CVS or in like a strip mall.
Right.
They don't have like. I think I'm sicker than.
They feel kind of like
Yeah.
pop up like.
Yeah.
You know what I mean? They're kind of like a Halloween spirit.
They really, yeah, they have become that.
Where it's like they kind of pop up
Yeah.
all over the place. I mean, some of them definitely have some more capabilities than others. Like, there's one locally to us that has the ability to CT scan, has the whole entire x-ray area, has an infusion
It's
area.
like one step below becoming a freestanding ER.
Yeah, no, I totally agree.
Yeah.
But I think that one is heavily used,
Yeah.
because they have those abilities. But I think that is important for the institutions to do it to help kind of educate the community because the staff that work here know.
Yeah.
It's not them that need to know where to go. So I think telling people is an important piece to saying like, hey, stitches and headaches and things like that, try an urgent care first.
I think from what I've seen, insurance companies, at least here in Massachusetts, are starting to also kind of say, here, you can go, these are your symptoms. And they're starting to also offer like a triage person that you can call and stuff like that kind of will guide you.
Phone triage.
Yeah.
Just to say where to go.
Yeah.
I think that's reasonable,
That
though.
used to be a requirement back in the day. You'd have to call your insurance company to kind of get approval to go to the ER. Because certain insurance companies only had deals with certain
hospitals.
Yeah, it was very zoned.
Now it's
ERs can't turn it away.
You can't turn anybody away.
And that's the other emerging trend. I think we can't turn anyone away. So you end up with winter coming, also becoming, and I know it's happening everywhere, but the indigenous, like the homeless population, end up going in because you almost end up being an emergency shelter.
Yes, for sure. I mean, it's like 16 or 15 degrees tonight. I mean, and a lot of the shelters within our area are full. I mean, I don't blame them for coming.
Right. So that also can impact the triage nurse, and everything like that too.
Wait times for sure. Yeah. All right.
I think that we hit it. That's all I had for triage. Overall, I find it to be a fascinating area to work. But it's also, like we talked about the sorting in the ESI a little bit. You do it all throughout, right? It guides the patient's stay, and in some places it guides what location in an emergency department they go to. But the area we call triage is where pretty much you walk in.
Right. I think one thing I do want to mention, and I'll keep it brief, documentation.
Oh, please, for the love of God, document.
Yeah. Because you have these increased wait times, right? I mean, we've seen some wait times that can be 20 hours.
Yeah. We have seen that person waited.
Right. And if those assessment pieces aren't completed and documented by the nurse, you've got nothing. You've got to take that time and put the assessment piece in. I mean, you're doing it out there.
Yeah. In most ERs, I haven't seen any that aren't guided by the principle of reassessment, revitalizing.
You have to.
Yeah.
You've got to see these people.
It's a humming little area.
Right. Because remember, you could have someone that could come in as a 3 with an abdominal pain, ESI 3 abdominal pain. And then in 4 hours, when you reassess them, they're a lot more sick. And they need to be up triaged. They have worsening vital signs. And that's such an important piece. It's like, okay, if you documented on them at 3 and I'm returning at 7 p.m. and I'm reevaluating this patient, I'm relying on your documentation to say, okay, well, when Jess was seeing this patient at 3 o'clock, what did she notice about them? Okay, well, now they're in here and their belly is rigid and they're walking in, hunched over.
It's now 125.
Right. Like that's an important piece to be able to watch that trend and say, oh, it looks like now this patient is actually kind of trending in a sicker direction. We really need to actually get them back at this point. And without your documentation at times, I'm not going to be able to kind of determine that trend for that patient.
And you might be able to up or down, not up or down, where they could go. So if they are worsening, oh, now they need to go to, not only do they should they get bumped up to be seen quicker, I need to make a, call the back of the house, get them back faster, depending on different ERs, and they have different zones.
Right.
So they try to zone off. This is where the most critical are. This is where like your urgent are, and some people will zone off. This is where your mental health are. Like they have different zones within the department, and you might be able to move to a different zone, which might have a less of waiting time.
Right. And that is in turn going to free up other space for people waiting.
Yeah.
So I think that that documentation piece is so important. And if you've got those increased wait times and you're not proving your assessment piece and the safety of the patient to wait during that time when you initially assess them, you're hurting yourself and the patient in the long run. It's so important to put that documentation in.
Yeah.
You know, if someone's here with a respiratory complaint, you should be listening to their lungs. You should be documenting that, proving why it's okay to sit out there and wait or why they shouldn't wait.
Yeah, it fundamentally goes back to like nursing 101 health assessment, right? You're going to do, it's one of the, not first times, but it's one of the, probably the most time where you're repeatedly doing almost a full head to toe.
Yeah, absolutely.
Yes, I'm here for a cellulitis, but I still have to look at a lot of other things.
Absolutely. Because you've got to determine if that patient can sit out safely in the waiting area.
Right.
And then if you've determined that, how do you successfully document that in the chart?
Yeah.
And
yeah, triage with your documentation helps you be like the detective, right? Like, oh, like my husband will not tell you that he has a medical history, but when you look at the documentation, looking at that, you can say, oh, yeah, but he's on this med, that med, and you start correlating, and you can add that to your documentation.
Yeah, I can't tell you how many times I've triaged patients and it's like, okay, any surgical, they're here for chest pain, for example. Any surgical history in the past? You know, just a couple things here that, okay, like what? I had a cabbage a year ago.
Yeah.
It's like, well, I know that you're done and healed and you feel great, but that's pretty significant.
Yeah.
For some people that think certain things aren't a big deal, it's so important to get like those little pieces. So the documentation is it's key to everything.
It's huge. You forget it really is the driving force.
Absolutely. And then when, our institution is quite large, so there's a lot of moving pieces and those people that are looking through the charts to really help sift through who needs to come back, they're also relying on great documentation from that triage nurse. It's so important.
Because it's not like a big room, right? It's not like the olden days where like, oh, I walk in, there's curtains everywhere. It's you walking into a room and there's 8 doors behind you where everyone else is.
Yeah. Right. And, ambulances and traumas and everything else coming in from a completely separate entrance that you can't even see. So, that person, that resource nurse or flow nurse or charge nurse or whatever it's called in your institution, it's important for them to be able to open it up and say, oh, just saw this person, and from her documentation and the patient's vital signs, they really are too. They need to come back.
I'm totally going off topic a little bit, but that reminds me of one other emerging trend I noticed when I was reading and even talking to other people through different like chats and social media stuff. Is one other big thing is they're starting to do triaging from almost the ambulances because of the wait times and stuff. There are some hospital systems that when the ambulance calls it, notifies like, hey, I'm coming in, they're calling into a dispatch center that's saying, listening to what the complaint is in the EMS assessment, saying, okay, I'm going to send you to campus A. Oh, you're Tony, I'm going to send you to campus B.
So dispatch is almost triaging EMS.
Dispatch is this particular, two of these particular health systems. The dispatch for the health system is it's either a paramedic or a nurse. It's a licensed healthcare person.
That's actually pretty interesting.
Yeah, it's usually in a system that has like kind of like the way our system is set up, where you have a couple hospitals close enough by that are owned by the same health system. So you're staying within the family,
right,
but going to a hospital that.
Right, because for example, like we don't house urology here 24/7.
Correct.
They primarily live at our sister hospital down the road. So if this urology complaint is heading our way, it would be wise for you to start at the other hospital because that's essentially where urology lives.
Yeah, and some of these dispatch centers are aware of wait times and acuity in the hospitals. So it's okay, you're coming in with abdominal pain. You know what? Like, we can get you seen quicker because we have the same services at Hospital B.
Sure.
So it almost, I don't want to say divvies out the EMS.
It's an interesting concept.
Yeah.
I've actually, I don't think I've ever thought of that concept. I tend to be a little closed-minded when it comes to anything kind of beyond our doors because I'm so hyper focused on everything within our
Yeah.
space.
So
But
there's definitely creative systems out there.
yeah, that's like, I think something that should be considered. I think that's interesting.
Thank you, everyone. See you again soon.